Welcome back to Midnight Med. This video is on antipsychotics. So as with all our pharmacology posts, we will talk about the different options that are available, the side effects, and things you have to monitor to make sure the adverse effects are not outweighing potential benefits, as well as overview the mechanism of action of these drugs. So the first generation of antipsychotics or typical antipsychotics were the first ones made, for example, haloperidol. They have a high affinity and high specificity to dopamine receptors, and they block these receptors. Now, it's not the best pharmacological or pathophysiological explanation, but basically when you have too much dopamine, it is thought, not 100% sure, that this causes psychosis. Dopamine makes you happy and active. Basically, if you have too much of that, you can go into psychosis, which is an altered perception of reality. The second generation, however, were made in response to some of the side effects of the first generation. Examples of second generation are quetiapine and risperidone. Because of the side effects by targeting specifically dopamine, these drugs have a low affinity and low specificity to dopamine receptors. They also inhibit serotonin, acetylcholinesterase, as well as adrenergic receptors. Clozapine is really the best drug in terms of treating psychosis. So then the question is, why is it not used as the first-line drug? And the answer is due to debilitating side effects. For example, neutropenia and agranulocytosis. Now, these can be devastating because if the patient does not have enough neutrophils, they are at risk of severe infections, especially bacterial infections. And that is not worth the risk of the reduced psychosis symptoms when the first generation and, of course, the second generation are good drugs. The patient may also develop heart failure with myocarditis and then later cardiomyopathy. So how do these work? We talked about these drugs inhibiting dopamine, but where do they inhibit dopamine? Where does the dopamine move? You don't need to know too much detail, but you have that kind of schematic showing the different pathways. And the mesolimbic pathway is responsible for giving rise to positive symptoms of psychosis, such as hallucinations and delusions. So blocking that pathway, you have reduced those positive symptoms. The mesocortical pathway is responsible for negative symptoms and psychosis. So negative symptoms mean stuff's taken away. For example, reduced cognition, or reduced energy, reduced care, so anhedonia. And when you block that pathway again, you're reducing those symptoms. The tuberoinfundibular pathway is responsible for symptoms of hyperprolactinemia. For example, you can have sexual dysfunction, galactorrhea, as well as changed menstrual cycles. Finally, the nigrostriatal tract is an important one, and you may remember that from Parkinson's, where you have a loss of dopaminergic neurons, and then you can have extrapyramidal symptoms. Now, the side effects are important to monitor, and these ones are relevant to all of the classes at varying extents. Some metabolic side effects include weight gain and hyperglycemia. Olanzapine is a particularly bad culprit for these side effects, and it's a second-generation drug. You can also get QT prolongation, leading to arrhythmias, and eventually VF and VT. You can have sedation, which patients may not find big a deal because they could find it useful to actually get to sleep if they're so hyperactive, as well as orthostatic hypotension, which is dangerous because it increases your risk of falls. Hyperprolactinemia, so sexual dysfunction, gynecomastia. Anticholinergic symptoms such as urinary retention, dry mouth, urinary retention being an increased risk of UTIs, dry mouth, dehydration, and then we can fall over. Extrapyramidal, because remember, if we're blocking dopamine neurons, we can lead to Parkinsonism. So this is not Parkinson's disease because the dopaminergic neurons are just being blocked, but it's still there. It hasn't degenerated. But you'll get similar symptoms like your movement disorders, difficulty starting movements, fascination gait, and tremors. can also get dystonia, and haloperidol is a particularly bad one for this because, remember, it's the strongest inhibitor of dopamine. Finally, you can get something serious but rare called neuroleptic malignant syndrome, and this is an emergency if a patient comes in with antipsychotics, and normally they'll have a tag or some kind of ID to say that they are on it, so this can be quickly identified. And it has these autonomic features such as high fever, neurological symptoms as well, with muscle stiffness, mental status change, and dysautonomia, so you can have changes in your heart rate and blood pressure. Finally, monitoring. So you want to monitor for these side effects. How do you do it? Well, metabolic. You can measure your BMI, your blood sugar levels, as well as lipids, focusing on diabetes and weight gain. White cell count and differentials, mainly that's for clozapine, looking for any neutropenia and agranulocytosis. So the differentials shows the level of the neutrophils in each of the different types of white cells. Finally, creatine kinase and troponins, ECG, echocardiograms to monitor for that cardiac dysfunction. Thank you for watching. I hope you learned something. If you did, please tell a friend who may also find it useful.